Welcome to PRI's podcast. I'm your host, Rowena Ichon. In this episode, Tim Anaya, PRI's Director of Communications, and I talked with Dr. Beth Haynes, Medical Director of the Benjamin Rush Institute and a Fellow at PRI's Center for Healthcare. If you're not familiar with the Benjamin Rush Institute, it's like the Federalist Society, but for medical students. Its mission is to educate medical students around the world on the benefits of free market enterprise in healthcare. BRI is present on some of the most prestigious medical school campuses across the country. Before entering the public policy world, Dr. Haynes was an emergency room physician and on the front lines of medicine. We discussed with her the bias on today's medical school campuses and their overwhelming promotion of government-run healthcare and the lack of voices advocating for free markets and the sanctity of the patient-doctor relationship. We also talk about Obamacare, exciting new medical trends, and the opioid crisis. Thanks for joining us. Dr. Haynes, welcome to our podcast. Before we launch into healthcare policy, how about giving our listeners an overview of the Benjamin Rush Institute, its history, its mission, and who is Benjamin Rush?
Oh, those are great. And thanks for having me on here. This is a wonderful opportunity. Benjamin Rush was one of 5 physicians who signed the Declaration of Independence. He was also part of the Constitutional Convention. So he was chosen to be the symbol of this organization because not only was he the father of American psychiatry, and an absolute staunch abolitionist, supporter of individuals and people, the common person. But as a physician, he got involved into the larger problems of politics and what was going on in the time. So we're encouraging the physicians and students to think beyond just medicine and how the rest of the way our society is constructed impinges on their ability to take care of their patients. So that's Benjamin Rush. And the Benjamin Rush Institute started off as a project within Pacific Research Institute. It was the brainchild of Sally Pipes, and we were underneath that for 3 or 4 years, and we've been independent for about 5 years. We work with medical students. If anybody's familiar with the Federalist Society, you can think of Benjamin Rush Institute as FedSoc for med students. We partner with medical students to help them set up events on their school campuses to talk about all the aspects of medicine that can't be covered in their standard curriculum. So medical ethics, how to run a business, the economics of healthcare, and healthcare policy. Much more, but that's it in a nutshell.
Dr. Haynes, the prevailing opinion among med students today is that the U.S. should move to a single-payer system. And a recent survey by Merritt Hawkins shows that 56% of doctors now support single-payer healthcare. Yet 10 years ago, the numbers were almost reversed, with 6 in 10 doctors opposing single-payer. How do you explain for this change in attitude?
I think physicians, well, there's 2 different things that are going on. One are the students who have always been more idealistic, thinking more with their heart, and that's fine. I mean, but they're also the products of our academic system in the United States, which tends to lean very heavily towards great comfort with government as the solution to all of society's ills. So that's why I think what's going on with the medical students and within their training, they're not exposed to alternatives. They're not exposed adequately to the downsides of government intervention into economic matters. As far as physicians go, I think it's just fatigue. It's being beat up by the system, being told it's a free market, seeing the destruction of their ability to really take care of patients without interference, and feeling like, we have to go somewhere. We don't know where to go. The single payer group is very loud. Physicians actually have a fairly easy time submitting the bill for Medicare if they quit thinking about all the other hoops that they have to jump through in order to get adequate reimbursement from Medicare. So this Medicare for all, from submitting a bill, sounds like, oh my goodness, I don't have to deal with all these multiple different insurance companies. It's just fatigue. A lot of it's fatigue, and they want to be doctors. They're being told that we'll let you just practice medicine and we'll take care of everything else. I think the other thing that's happened is with the ACA, with the Affordable Care Act, there were so many onerous requirements set on for reporting quality, for the kinds of things that they need to do in order to be reimbursed by Medicare, that then got followed also by many of the insurance companies. And the pay is getting squeezed, all these things. There's been huge consolidation, and a lot of the smaller practices have given up. They've become employees, sold their practices. And so we don't have that unique role of the small independent businessman anymore who wants to really speak out and fight for their small business.
I'm sure that Washington's inability to repeal and replace Obamacare was deeply disappointing to you and so many of us. But you think that most of the progress and reforms are happening in the states. Tell us a little bit more about that.
Well, I think as the recent back and forth and the failure for there to be really any progress in Congress just illustrates why it's so dangerous to make medicine a political problem. Things are going to move at the speed of Congress, right? It's going to take an act of Congress to make any kind of change. And look how divisive it's made the whole issue. The politicians, some are really good and mean well, but they have to be reelected. So they can't, it's just all politicized instead of really being able to deal with things on a much more basic level. And because of that, the closer the politics is to home, the more I think that this individual citizen can actually influence what's happening. So I think there's a lot we can do at the states. There's a lot of movement that we can create, tremendously exciting innovations in healthcare delivery that all we have to do is keep government from crushing them by adding new requirements and obstacles. And we're going to see some really incredible things happen in the United States. So Washington, they've got to have those fights, let them have it. But I think that a much higher return on the investment is going to be at the local and state levels.
Since Obamacare has been in place, what are, in your view, some of the major changes and trends that you've seen in the practice of medicine?
Oh my gosh, burnout is absolutely skyrocketing. And a lot of that has to do with the pressures of the laws and regulations that are intruding themselves in between the doctor and the patient, telling the doctor what they have to do, how much to charge, what are the boxes they have to check. So it used to be called paperwork. It's now called quote unquote desktop medicine, but it's like the computer equivalent of paperwork. And for every hour of patient care, a doctor is required to spend 2 hours on this desktop medicine. Nobody became a doctor to click boxes. We've got some of the highest paid data entry clerks in the world. That's what we're turning our doctors into. And without that human to human connection where you're feeling like just overwhelmed with trying to do what you can for your patients, it's doubled the work. So we're seeing this tremendous amount of burnout, depression, highest rate of suicide of any profession in the United States. It's horrible. And the patients don't like it either. The doctors are able to spend less and less time with their patients. So not only are they spending more than half their time with the computer, even during that face-to-face time with the patient, probably a third of that is spent staring at the computer screen. Not because that's what the doctor wants. So it's sucking the life out of physicians. The other thing we've seen, which I mentioned before, is the increased number of employed physicians. And I don't have any problem with the employment model. That works for a lot of people. I have a problem when the federal government sets up its laws and regulations that it drives people that way. It's makes it so onerous to try and be a small independent businessman that it's getting harder and harder and for people to be able to do that and financially survive. So there's fewer number of independent small business practices.
From the perspective of physicians, what are the top 3 issues you would like to see addressed by Congress and this administration?
I think they all center around the idea of empowering the patient in order to have a much more direct doctor-patient relationship. And doctors and patients both need to think about the cost of the treatments that they have. There's this push for mandating transparency. Transparency of prices will occur when the patients and the doctors actually have to care about what it costs, and they don't right now. And even if they do care about it, there's no way to figure it out. So whatever we can do to empower the patients and the doctors to really have those dollars in their own hands and not have a lot of intervention to tip the economic balance one way or the other. So things like that would be equalizing tax treatment of all medical expenses. And what this would do is no longer favor employer-sponsored health insurance. We have this whole, what people refer to as pre-existing conditions problem, but I think is better characterized as uninsurable condition problem because people's insurance has been tied to their employer for so long. If people owned their own health insurance because there was not a tax penalty for owning your own health insurance, it would be portable. It would go with them. People would not have the gaps that we wouldn't have people lose their insurance and then have these uninsurable conditions. The other thing that the feds could do is is recognize that direct primary care is not a health plan. That's part of this tax treatment. Right now, people cannot use their health savings accounts to pay their direct primary care. They can't claim their direct primary care membership fees as a tax deduction without jeopardizing their ability to even have an HSA. So those are a couple of the main things that I would say is equalize tax treatment of all medical expenditures and recognize direct primary care by the IRS that it's not a health plan.
Let's turn to Medicare and Medicaid, which are two of the big drivers of costs. Doctors are finding it more and more difficult to accept Medicare and Medicaid patients because reimbursements for treating these patients are so low. Not to mention all the red tape and paperwork that you've mentioned it takes to receive the reimbursements. So as a result, more and more people are turning up at the emergency room. As a former emergency room physician, give us your perspective. How can we remedy this issue?
This is a huge one. What we have done is we've priced so many people out of affordable health care that more and more people have been put into that category where they have to rely on the government to be able to pay for their medical care. They're the biggest victims. Our sick and our poor are the biggest victims of the healthcare system, and it's been totally doubled down on by Obamacare. We have to figure out a way to empower the individual and really return to a true safety net. Until we do that, we're going to have to continue the subsidies for these people, even the middle class now that are being more and more priced out of affordable health care. But one of the things that I think is super important is part of the reason that so many of these Medicaid patients are ending up in the ER is they can't find a doctor who can afford to take them. If you put in the poor reimbursement that Medicaid does and the extra hassle that Medicaid puts on every physician, they can't afford to have very many Medicaid patients in their practice. So they don't take them. So if we could do something like the way Safeway doesn't care if you hand a card and it's like a debit card from the food stamp program, or if you're handing them cash or your credit card or your bank card, they don't tell because they're getting paid exactly the same for their goods and services from everybody. There's no price differential. And we need to be able to do that for our low income folks so that when they show up at a doctor's office, there's no reason to discriminate against them. Healthy Indiana was a really fascinating experiment. Wasn't perfect. There was a lot of problems, but it empowered the individual Medicaid patient to be able to go to the doctor, and the doctor was not experiencing these severe, much lower reimbursement rates and much higher hassle factors. So empowering those individuals to become responsible healthcare consumers and putting the dollars in their hand, I think would go a long way to solving the access problem for Medicaid patients.
Dr. Haynes, in a related issue, we're now seeing a shortage of primary care physicians. You're around medical students. Why do you think fewer doctors are becoming general practitioners? How can we encourage more doctors to go into primary care?
Oh, gosh, if you ask, there's actually some pretty good surveys out there. Physicians Foundations have done some. And what are some of the reasons that medical students are not going into primary care and our existing primary care doctors are quitting? A lot of it has to do with all those regulations and laws that increase the amount of paperwork and so forth. So there's a great study that we assisted. Actually, it was a physician's assistant student where he gave a survey to medical students before and after hearing a lecture about direct primary care. And but people don't know what direct primary care is. You can think of it as like a membership medicine. You pay a monthly fee, very affordable, less than the cost of, and for that you get your primary care. You get all the office visits, anything you want that can be done within the office. And many times these doctors get extremely discounted costs for services outside of their office, labs, diagnostics, specialty care, so forth. So once the medical students hear about this direct primary care and the amount of time that the physicians can spend with their patients, the types of relationship they have with them, we see the students that are interested in primary care go up. It's like, wow, this is like being the kind of doctor I went into medical school for. This is really great. So I think finding more of these models that empower the physician to be the kind of doctor that they want to be and unencumbered by all the pointless paperwork and regulatory requirements and really gets that direct doctor-patient relationship back in. That's, I think, you're going to revive the interest in primary care. I'm seeing it in a lot of docs who are ready to retire. Now, I was ready to quit until I learned about direct primary care, and now I can do this and have fun. I was just this past week at a direct primary care conference, and in spite of the fact that there's a 75% burnout rate, the physicians, 75% of physicians show at least one out of three criteria for burnout. 80% to 90% of the doctors in that room were saying they love what they're doing and feel positive about the future of their practice. So that's going to be a big solution.
So the doctor-patient relationship is changing. It used to be that, for example, the same pediatrician would treat all the children in the family. I know that was the case for my brother and I when we were growing up. And primary care physicians would treat several generations within a family. Now, it's difficult to get a hold of your doctor. I know in my case, I go to UC Davis. You have a different primary care doctor every 2 to 3 years. What's driving this more impersonal relationship between doctor and patient?
Well, I think, there's some real advantages of being an employed physician from the physician standpoint where they might have more limited hour requirements, many more people to share call with. But some of what you're describing is the result of that, where medicine becomes more like a shift work, or they're less invested into the practice. So there's more movement that's going on and people don't stay. So I think many of the ACA's requirements pushed people to sell their practice. We're seeing larger and larger corporate medicine, and it creates a different relationship between the doctor and the patient and the doctor and their own practice. And again, it's been driven by the reporting requirements, none of which have been shown to increase any kind of quality. There's no evidence that all these reporting requirements actually improve quality. So the time and money that it takes to comply drives the physicians to sell their practices. They get gobbled up by these large corporate businesses, and there's a different attitude about their work.
Let's chat about the opioid crisis. It's been a top priority in the Trump administration. As proponents of less government, we're concerned that well-intentioned programs often make things worse. Take the war on poverty and the war on drugs. Is there a role for government in the opioid crisis? And if so, what should it be, and what shouldn't we do so that we wouldn't have adverse consequences that we've seen in other social issues?
Well, Jeffrey Singer has written a couple of articles recently. I know one was published in Reason magazine. I can't remember the other one, but he completely debunks this myth that physician prescribed prescription opioids is anything more than a minor contributor to what's going on. And I think that really needs to be taken a look at, because so many of the solutions that are being posed are putting greater restrictions on individual physician ability to decide the best way to manage the pain of their patients. And what this is doing is making legitimate use of opioids and people with pain, whether it's acute or chronic, makes it much more difficult to be adequately treated. And for those who it drives them into the illegal market for these things. I mean, it's just, so we're treating a problem that doesn't exist and blaming physician prescription because of a few high profile cases. So it's bad policy. I think the role for government is to prosecute the criminals, right? Find the criminals and prosecute them. Don't make it harder for the vast majority of legitimate physician and legitimate use of opioids for their use. I mean, this pendulum is swinging completely back. When I was training, everybody was afraid of turning people into addicts. And we learned more and more that you actually use less medicine if you use it appropriately. And we got patient-controlled analgesia in the hospital, and pain became the fourth vital sign, and all these things. And we're not looking at the entire problem, but you make sure that your laws are only prosecuting people who are doing illegal, illegitimate activities with this, and make sure that we're not punishing particularly the patients. The patients are the ones who are going to suffer the most here.
It seems like whenever we talk about healthcare or medicine today, it's always negative. So let's talk about the positives. What are some of the advancements in medicine that you're most excited about, and how can we keep this innovation going?
So we've been talking mostly about healthcare delivery, and let's just stick with that. What are some healthcare delivery innovations that are going on that we don't have to sit around and wait for the politicians to allow us to do, at least not completely? There's some obstacles that it would help to remove. I mentioned direct primary care. Again, for the cost less than that of your cell phone, you can get primary care. The patients that are flocking to this model are the uninsured, the underinsured, the lower middle class and upper lower class that really want that continued meaningful doctor-patient relationship and access to their physician when they need them. So look at direct primary care. Other things that are going on are these cash-based ambulatory surgery centers. Surgery Center of Oklahoma, Free Market Surgery of Texas. There's a number of these that are going on that will take cash, and when they have these bundled cash prices that are posted on their website at 1/10 to 1/7 of what the supposed not-for-profit hospitals, supposed charity hospitals are charging. And if you ask Keith Smith, who started the Surgery Center of Oklahoma, how can you keep your prices so low? He says, that's the wrong question. I'm giving this to you at a reasonable cost. You got to be asking why the hospitals are charging so much. So we're seeing movement in there, and a lot, more and more surgeries and procedures can be done outside of the hospital. There's also some move for bundled inpatient pricing that we've seen down. Some friend of mine who has Epiphany Health, it's a direct primary care in Port Charlotte, Florida, has now worked with a local small community hospital to have bundled pricing for hip replacement and knee replacement. So we're going to get some more push on that towards the hospitalized procedures. And we need to look outside of our own country. There's some super exciting things coming out of India. There's the Aravind Eye Care, which is a nonprofit organization that's been able to get the price of cataract surgery around $100. I mean, that's 1/10 of what it costs here. And Devi Shetty, who started off in India with Narayana Health Systems, is a for-profit hospital, and he's got cardiac surgery that is $1,800. His goal is to get it to be even lower than that. Cardiac surgery in the United States is $60,000, and he's doing it for $1,800. He built the health city in the Cayman Islands, which was a place he could get close to the United States without having to be in the United States, because he could not offer his low-cost, high-quality care in the United States. They would drive his price up, and he could no longer meet his goals of keeping the cost down. So we need to see what these two systems are doing. How can we recreate some of that in the United States? So some real exciting stuff that's going on out there in the delivery of care that's keeping that quality high, making it more affordable, and that's going to increase the access for another huge chunk of people who've been priced out of affordable healthcare. It's going to make them affordable, and we can start getting back to making our safety net truly a safety net.
Dr. Haynes, you've been a critic of the one-sided information physicians and medical students are exposed to in terms of healthcare policy. Tell us about the Benjamin Rush Institute's efforts to try to remedy and counter this one-sided bias that a lot of physicians and medical students are getting these days.
The major goal that I see for Benjamin Rush Institute is to really broaden the conversation about healthcare policy and medical ethics. It's just not happening right now. If students get much health policy at all during their formal curriculum, it's heavily biased towards government is the solution. We have to solve this with more regulation, different laws, and there's really an animosity towards free markets that is completely undeserved. But even if people don't agree with me, I think that we cannot have a complete conversation or full understanding of the problem without a back and forth, without a point and counterpoint. And they're not getting that counter to their government is the solution. So that's what Benjamin Rush wants to do, is come in and say, let us present what we can tell you, here's the holes in your argument. Here's where single payer has some major flaws. And they're more than welcome to come back and say, here's where the free market, has people fall through its cracks, but have that full conversation. And it's not only happening within academia, but it's also a problem within our professional organizations. The AMA right now has a huge proportion of its funding comes from the royalties on the coding numbers that occur through Medicare and the traditional insurance program. They're not from physician fees. So consequently, only about 20% of doctors belong to the AMA. Now, many more belong to are specialty organizations. But even with that, there's all those specialty organizations are heavily influenced by academia and by people who are much more government friendly. So we're not getting that appropriate balance of the conversation, the challenge to these status quo way of thinking. It's just not happening. So we need, that's what we're there for. Try and stir that pot a little bit, hold their feet to the fire. If they're going to argue in favor of these things, they need to be able to answer and explain what they're going to do about the problems that their policies are creating.
So with all of this heavy talk, we always like to end these podcasts on a light note. It's our tradition here on PRI's podcast to ask our guests to recommend a favorite wine or cocktail. And since we have a doctor in the house, we will always say all things in moderation, of course. So please share with our listeners your recommendation for a favorite wine or cocktail.
Sure. And it's really pretty interesting because when I was training there, and still what's going on, the party line is we need to have low fat, stay away from fat, and we want lots of healthy carbohydrates, so on and so forth. Well, my recent reading has been showing that this is not such a great idea, and it may have heavily contributed to the obesity and diabetes epidemic and may not have helped the problems with the cardiac. So I've been reading a lot of stuff about low carb. So here's my new favorite drink. It's a low carb drink that's known as the Northern California Skinny Margarita. And
I've had that.
You've had that. So it's a shot of tequila. I use a shot of lime juice, and then you fill your glass up with sparkling water. So that's my current favorite.
I'm having some people over for paella tonight. I might have to try that and serve that to my guests.
It's a low carb. What's really interesting is that alcohol, before we had insulin, to treat diabetes, we used IV alcohol because it doesn't stimulate insulin. So pure alcohol actually doesn't have that diabetogenic effect. In moderation.
And for our listeners, if you think our opening jazzy introduction is a little different this time, we actually have a special artist opening Dr. Haynes' podcast, and it's her daughter, Eva. Where is she, Beth?
She's now in Nashville, and her last name is Cassell. And yeah, she's just recent graduate from Berklee College of Music in Boston, and she's got her own CD called Everything. You can get it on iTunes. And I love that intro about the San Francisco, coming home to San Francisco. It's beautiful.
Thanks, Dr. Haynes. Thanks again to our guests, Dr. Beth Haynes, and to Tim Anaya. If you're a physician or a medical student or know someone who might be interested in the Benjamin Rush Institute, please visit their website at benjaminrushinstitute.org. If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, or TuneIn. And please do us a favor and give us 5 stars. You can also listen to our podcast on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Also, check out our new blog, Right by the Bay, on the website at pacificresearch.org. Thanks for listening. I'm Rowena Itchon. We hope you'll come back again for another episode of PRI's podcast.